Good evening, everyone, and I sincerely welcome you all to this meeting on behalf of Apollo Cancer Center, Chennai. I am particularly delighted and honored to welcome Dr. Deborah Enting from the Guy's and St. Thomas Hospital, United Kingdom. And we also have very strong Indian faculty today. So I welcome all our Indian faculty and our Indian oncology colleagues who are all with us for this meeting. And as we know, we have been, all hit by this global pandemic for the past 1 year, and cancer patients took the brunt on both fronts with their disease, and also to face the reality of how to manage their disease in the times of COVID. So, for protecting our cancer patients, most of the hospital reflexly went into all the protective modes, and screening became an important tool, triaging became an important tool, and universally all hospitals adopted these policies of robust screening at the entry and triaging the patients, and then insisting on personal hygiene, hand washing, hand rubs, masks, social distancing became the norm. And social distancing, and also adopting unique policies within the hospitals, within the lift, as you see here, and also rigorous cleaning of all frequently high touch surfaces. And this is one of our staff cleaning the even the buses that commute to the hospital staffs. So this became the norm for how do we deal with COVID and protect our cancer patients from the hospital front. Apart from completely re-engineering the hospital wards, including the intensive care and the emergency rooms, that's what we all did. Finally, I think at this point we believe that the light is visible at the end of the tunnel, and we believe the vaccine has arrived to the save everyone, and particularly the cancer patients. That's what we believe. But then, uh, you know, um, at the end of this pandemic, with all these PPE and all, the battle is still going on, but there are still some questions remain. These questions are posted in the American Cancer Society website, and these are the current questions that are prevalent in the minds of all our patients. That includes: is it safe for cancer patient to get any type of vaccine? Which vaccines are available? What is meant by emergency use authorization? And what are the side effects of the vaccine? Are the COVID-19 vaccines available for cancer patients? Should cancer patients or survivors get the vaccine? And if I have such and such disease, am I okay? And what about the caregivers? And will a general flu vaccine prevent against COVID-19? And where can I get more information about COVID? These are very, very pertinent, very, very relevant questions in the minds of our patient. And this seminar with very eminent faculty, from United Kingdom and from India, is trying to address some of these issues. So I welcome you all, and we'll move forward. I request Dr. Parvish Parikh to take the lead from here and take us forward. Parvish, bye.
Thank you very much, Dr. Raja, for setting the context. And I think you really raised the most important questions. We have none other than Dr. Abdul Ghafoor, our ID specialist, to walk us through what is the current scenario. So, without wasting much time, I will hand over to Dr. Ghafoor, please.
Thank you, sir. Am I audible, sir?
Yes.
Good evening. India initiated world's largest COVID vaccination drive on 16th of January this year. So far, we have vaccinated 10 million at-risk frontline workers in our country. The beginning of March, we will initiate vaccinating the public at risk, and at that time, we will have an opportunity to vaccinate our beloved oncology patients. We all know that the cancer patients are at risk of COVID-19 associated complications, especially those patients with hematological malignancies, lung malignancies, and metastatic disease. Overall, patients with solid tumor appears to suffer an increased risk, even though less likely than hematological malignancy. But even those solid tumor, especially within first year after the diagnosis, and later the risk come down after 5 years. For any malignancy, active disease confers a significantly increased risk of severe COVID-19. Now, this is the data recently published meta-analysis of hematologic malignancies and COVID-19. Overall, adult oncology, hemato-oncology patients admitted with COVID-19, the mortality rate is 34%. It's pretty high. While pediatric hematology patients, 4%. And let we all know that the general population has got a mortality around 2 to 3% maximum, where our adult hematology patients is 34%. There is no obvious difference in the risk whether the patient is on active chemotherapy or not. That's very interesting. The relative risk is 1.17, even if the patient is on active chemotherapy or otherwise. Patients aged more than 60 years had a significantly higher risk of death compared to patients less than 60 years. Now, let's see what our NCCN colleagues advise us. The cancer patient should be immunized when the vaccination is available to the patient. That's a very tactical recommendation. Patients should be immunized when the vaccination is available. At the same time, we should have the understanding that there is limited data on the safety and efficacy in oncology patients. We should not forget about the caregivers and household and close contact of our oncology patients. Should we vaccinate cancer patients who have recovered from cancer? Yes, we should even vaccinate patients who have recovered from cancer. They should also receive the vaccine. There are two types of vaccines available in India. The Covishield, that is Oxford University, AstraZeneca Serum Institute vaccine. It's a non-replicating adenoviral vector. We all know that the scientists have removed the genes responsible for the replication of the adenovirus. The adenovirus is live but cannot replicate, even in immunocompromised patients. And we have another vaccine called as Covaxin by Bharat Biotech, Indian company. It's a killed virus, whole virion killed vaccine. We don't have any of the mRNA vaccines in India so far. The J&J adenovirus vector vaccine, the Sputnik adenovirus vector vaccine, and the Novavax protein subunit vaccine may be introduced in the country in the coming months. This is the summary of the NCCN recommendation. HSCT patients, we can initiate vaccination after 3 to 6 months. So we have to wait for a minimum of 3 months. This is a general recommendation. And hematological malignancy, AML injection, we have to wait till the count recovery. Other diseases like prolonged marrow failure, and we don't expect a marrow recovery, you vaccinate when the vaccine is available. And myeloproliferative neoplasm, vaccinate when the vaccine is available. Solid tumor, vaccinate when the vaccine is offered and made available. This is a summary of NCCN recommendation. Let's go to the details. There's an excellent document prepared by our colleague from Memorial Sloan Kettering, a very useful guideline. If there is a deficiency of vaccine available in the country, we should prioritize. And whom should we prioritize? Patients active on cancer treatment, especially hematopoietic transplant patients and hematological cancer patients, And those patients we are planning to initiate chemotherapy, or those patients that received chemotherapy within the last 6 months. These are the patients at the highest risk. If there's a deficiency of vaccine, we should prioritize these patients. And of course, we have to consider other non-oncology risk factors like age above 65 and other comorbidities into our calculation. Vaccine and chemo cycle. In patients receiving chemotherapy, we don't know the optimal timing of vaccination in relation to the cycles of chemotherapy. In the absence of data, we recommend vaccination when the vaccine is available. Very interesting and practical point. Now, hematological malignancies. We know that many of the patients on active chemotherapy in hematological malignancies may not mount a response, a proper response to vaccine, at least a category of patients. Even then, we can go ahead with vaccination, praying the vaccine is going to work. One group of patients on lymphocyte depleting therapy like our rituximab, alemtuzumab, and ATG, in a higher setting, we may have to go ahead with the vaccination when the vaccine is available. But at least there are some parts of the country with low transmission setting. In this particular areas, we may have to prioritize and give the vaccine to the patients at the right time. I don't know whether it will be feasible in our country because we may have to consider the country at high risk. So in low transmission setting, this is a possible suggestion. It is reasonable to consider deferring vaccination until 6 months after the completion of lymphocyte depletion therapy. We don't know how practical it's going to be. Otherwise, we can look for lymphocyte reconstitution. Do a flow cytometry. If the B cell count is more than 50 or absolute lymphocyte count more than 1,000, we can consider giving COVID vaccination. At the same time, if we can spare some time to initiate the lymphocyte depletion therapy, we can ideally give both shots of the vaccine and then wait for 2 weeks before initiation of lymphocyte depletion therapy. But that, as we know, may not be feasible in many cases. Now, high transmission setting, we are going to go ahead and give the vaccine even on patients receiving lymphocyte depletion therapy. The reason is we know many of these drugs suppresses the B cells. We need B cells for the antibody, but still may have an acceptably active T cell memory. And the early protection of the COVID, the antibody prevents the early disease. At the same time, it's the T cell that reduces the severity of the disease. So even though B cells may not be functioning, even though there may be a blended antibody response, we can still anticipate a level of functioning T cell memory. So still, whatever benefit it gives, we will go ahead and give the vaccine. In a CLL patient, especially on rituximab or venetoclax or ibrutinib, in high-risk transmission, we'll go ahead and give the vaccine. That's an option. In low transmission setting, if oncologists can, if you can postpone the CLL therapy, if the patient is asymptomatic from a CLL transplant, that would be wonderful. And we can hold the B-cell depletion therapy at least 1 month after the completion of both doses of vaccine, only if feasible. And for small molecule therapy in symptomatic patients, hold the vaccination until 1 month after completion of treatment, until the lymphocyte reconstitution. But this is only in low transmission setting. Even in low transmission setting, when chronic therapy for symptomatic patient is required, just go ahead and vaccinate. We can't wait forever. By high transmission setting, we have to go ahead and vaccinate. B or T ALL. Avoid vaccinating during induction. Wait for the count recovery, except in low intensity conditioning cases where we give steroid plus TKI. We may consider vaccinating even during induction. Otherwise, wait for count recovery. DLBCL and other aggressive B-cell lymphomas. Of course, we are not going to delay the systemic induction therapy, including anti-CD220 antibodies, just for vaccination purpose, we'll go ahead and give the induction therapy, and high community transmission setting, we will go ahead and give the vaccine when the vaccine is offered. When low transmission setting, we can prioritize till we complete the therapy and waiting for remission and no further treatment is planned, and of course waiting for B-cell recovery. But India, still most part of the country are high risk setting, high transmission setting, and we may have to go ahead and give the vaccine. Indolent lymphomas, again, high community transmission will pray the T-cell memory will work even though there is no B-cell recovery. We'll go ahead and give the vaccination. In low transmission setting, we can prioritize. We can, if possible, postpone the cell depletion therapy until 1 month after the completion of vaccine, if feasible. Otherwise, if you already started the induction, then complete the induction without maintenance and give the vaccine in between if there is lymphocyte reconstitution meanwhile. T-cell lymphoma, again, we are going to go ahead and give the chemotherapy rather than waiting for the vaccination. And during induction, if possible, wait for the count recovery before giving the vaccine, if possible. At the same time, lymphoma patients with relapsed or refractory, we are going to go ahead and give the chemotherapy and meanwhile give the vaccine as well. Myeloma, as we know, most of the patients, we can go ahead and give the vaccine when the vaccine is made available. Myeloid malignancies, AML, as we all know, we have to wait until the count recovers. MDS, we'll go ahead and give the vaccine. Myeloproliferative neoplasm, we'll go ahead and give the vaccine. CML, we'll go ahead and give the vaccine. Therapy-specific recommendation. Of course, steroids, it's always better to have a gap, but it's not possible in most of the cases. We will go ahead and give the vaccination. IV, IgG, if necessary, we can administer to those patients who are receiving vaccine, no problem. Checkpoint inhibitors like pembrolizumab, we are going to go ahead and give the vaccine rather than waiting. We can give even on the same day of immunotherapy. Otherwise, if possible, give a few days gap because the vaccine can have systemic symptoms. So we don't want to combine both a checkpoint inhibitor therapy and the vaccine on the same day. But if you really want to go ahead, we can go ahead on the same day. Maintenance therapy, we know rituximab, ibrutinib, and JAK inhibitors are going to blunt the immune response. But if necessary, we are going to go ahead and give the vaccine. Autologous HSCT, wait for 3 months. Allogenic, in usual circumstances, no severe GVHT and no anti-CD20 treatment, we will go ahead and give the vaccine in 3 to 6 months. Moderately severe GVHT, we will vaccinate. When will we postpone vaccination? Severe uncontrolled GVHT, grade 3 or more, or on anti-CD20 antibodies with inadequate lymphocyte recovery, inadequate B-cell recovery, or those received alemtuzumab or CAR cell patients with B-cell aplasia with B-cells less than 50, we may have to postpone the COVID. Now, this is one area we really have to discuss. Should we really postpone or go ahead and give the vaccine when the vaccine is made available? We need to discuss in detail. Solid tumors we discussed. We are going to go ahead and give the vaccines. There is no specific timing is recommended when to give the vaccine. So we'll go ahead and give the vaccine. If feasible, postpone the chemotherapy 2 weeks after the COVID vaccine. If feasible, wait till the chemotherapy is over. But that is only in low prevalence setting. In India, with high prevalence setting, we may have to go ahead and give the vaccine. Surgery, cancer surgery. There's no specific timing is recommended. We can go ahead and give the vaccine, but it's better to give a gap of few days because these vaccines are going to have some kind of side effects. And we don't want to confuse that with the perioperative other complications. Leave a gap of few days. Splenectomy, leave a gap of 2 weeks before the splenectomy and 2 weeks after the splenectomy, as we do with other vaccines. Pediatric, so far straightforward, no vaccine is licensed for children below 16 years so far. So for the time being, we don't have to discuss this. Should patients receive additional dose of vaccine if their second dose was after the recommended time? We know that because of the chemotherapy, we may have to delay the dose sometimes. Should we give another dose? No, we don't have to give a third dose. There's no recommendation for that. Should cancer patients get revaccinated if the vaccine was administered during a period of immunosuppression? No, revaccination is not recommended at this time. Will a booster dose of vaccine be needed in the future? So far, no. We are going to give 2 doses of most of the vaccine. Is it safe to receive other vaccines with the COVID-19 vaccine? We should always, it's better to space other vaccines, at least 2 weeks from the COVID vaccination. Give a space of at least 2 weeks for the COVID vaccination. This is one important area. Managing severe allergy, especially those patients who have immediate type of severe allergic reaction like angioedema, urticaria, anaphylaxis to any of the components of the vaccine. Especially, we know that mRNA vaccines contain PEG, the polyethylene glycol. And we know that some of the adenoviral vector vaccines like Covishield contain the sorbate, polysorbate. And polysorbate and the PEG cross-react. So, any of the previous history of, for example, first dose, any of these severe reactions, let's avoid we should not go ahead with the second dose. There are a lot of drugs, lot of our monoclonal antibodies contain PEG or polysorbate. If any of these patients had immediate type reaction like angioedema, urticaria, or anaphylaxis to any of these drugs which contains PEG, and the big is very least among oncology drugs. Even antibiotics like vancomycin contains PEG or polysorbate. So we should be careful, but only those patients who had angioedema, urticaria, anaphylaxis, not patients with mild allergy or other delayed type of hypersensitivity. So as much as possible, we have to vaccinate all our oncology patients. In India, we may have a logistical issue because patients have to register online. They will be given an appointment. What we will do, if a patient AML, ALA injection or BNT within 3 months get an appointment, we may have to find an option of postponing their appointment. So we have to discuss about the logistics of vaccination of our cancer patients. And it would be better if all the oncology centers initiate their own vaccination center so that they don't have to stand in a queue with the non-oncology patients. So we may have to find a way of initiating COVID vaccination in all our major oncology centers in the country. Thank you.
Thank you, Abdul. That was really fantastic. And you have touched so many of the important points. I hope that we can discuss further in the panel discussion that we have now. So we'll straight away move to the panel discussion. With your permission, I will start sharing my screen. Thank you very much to Apollo Cancer Center for giving me this opportunity. And here is the list of our esteemed panelists who are there with us. Dr. Debra has kindly agreed to join us from the United Kingdom. And they are facing a real problem. So we will hear from the horse's mouth, so to speak. And Dr. J.P. Agarwal is from Tata Hospital, radiation oncologist. Dr. Govind Babu is president of SARC Federation of Oncology as well as ISMPO. Dr. Hemant Malhotra is a very important member of the drug authorities special committees and a senior medical oncologist. And we have others like Dr. Nitin Bansal, Dr. T.P. Sahu from Bhopal, Dr. Arvind Krishnamurthy from Chennai, Dr. Amish Vora from Delhi, Dr. Shyam Agarwal and Dr. Amit Agarwal also from Delhi, Dr. Vijay Anand Reddy from Hyderabad, Dr. Sevanti Limaya from Mumbai, Dr. P.N. Mohapatra from Orissa, and Dr. Senthil Rajappa from Hyderabad. So we have a galaxy of people, and I'm sure that all of us are eager to listen to their opinion. So this is how the story really started, and I've just tried to compare what happened in important Western countries as opposed to what has happened in SARC countries. And you can clearly see that while January was very important for the Western world, that was when it got initiated in Nepal and in India. but the rest of the SAARC countries, actually got their first patient in February or March. And this is the status globally as of yesterday, February 18th. Yesterday, there were 300,000 plus new cases and almost 10,000 deaths. As compared to that, let us look at what is happening in India. And I have specifically compared to 10 January and yesterday, that is February 18, because there has been this concern about the so-called second wave in some parts of our country. So you can see that as compared to 10 January, our cases are still low. And as compared to 10 January, the number of deaths are also low. So there has been a lot of lessons that we have learned, particularly how it has affected academic activities. And therefore, let me start with Dr. Debra. Uh, Tell me how you have been able to participate in academic activities and share your inputs and your knowledge with your colleagues and rest of the world as far
Thank
as
you.
COVID is concerned.
Yes, no, thank you. So I think most of the activity we saw initially last year, when obviously we were, so just to give a bit of context, I work at Guy's and St Thomas's, which is a large general kind of health trust in South London. And we are split over two sites. One is opposite the House of Parliament, so near Big Ben, and we're next to the Shard, which is the big pointy building, which is where we have our cancer centre. We treat and see 40,000 patients a year with similar amount of treatments, and we treat both hematological and solid malignancies. And we have close relationships with King's College Hospital, which is just a few miles down the road. So last year in the first wave, which started in March when we went into lockdown in the UK, we saw mainly healthcare workers initially kind of fall sick in terms of colleagues, other clinicians and nurses. And whilst we were very concerned at the time that especially our cancer patients were very vulnerable and might develop nasty COVID and die as a result, I think in reality, we saw that very little initially. And I think partly that had to do with the fact that our patients were shielding and quite early on, and they were generally scared to come out of their houses. Many patients stayed away from hospital, and that obviously caused a concern. And some of the academic kind of outputs have focused on that in terms of kind of delays in diagnoses. So one of the big papers that came out in the Lancet Oncology in July last year was actually the impact of a delay in diagnosis during the first wave of the pandemic, and the impact on mortality, which was excessive. And that was just showing that for breast cancer, lung cancer, upper GI cancers. And I think there was one other cancer involved. So, it kind of showed us kind of the fear of what we were seeing, that patients weren't presenting, but obviously cancer doesn't stop, and ultimately had a detrimental impact on them. I think the other key message that we brought out, that the patients generally, that are current patients who are on therapy, even on chemotherapy and systemic therapies, although they might develop or be positive, some of them develop symptoms, but the majority were fine and they've recovered. And we actually saw remarkable kind of low levels of mortality for perhaps our own kind of patient cohort, a lot lower than what we initially had expected. And we've published that at various kind of platforms, mainly at obviously in journals and also at conferences. Right. And the other big piece of work that came out was in Cancer Cell, which was from my colleague Shiba Ershad, that came out in January this year. And she did immune profiling on a large number of solid and hematological malignancies of patients who had contracted COVID. And what she showed is that the immune responses of solid cancer patients, despite their kind of therapy, they had very similar immune responses to healthy volunteers and healthy controls. But there was a big change for the hematological malignancy patients in the sense that they had poor T cell responses, and they tend to kind of shed the virus a lot longer. So that was a big, really important piece of work, and that's now continuing in terms of kind of the responses after vaccination. So I think, that's some of the kind of highlights and the kind of the positive angle of kind of what we've seen in the last year, that we can work together and actually pull together, large data sets of our own patients and collaborate with other centers.
Right. Now I'll move to Dr. Govind Babu. What has been your experience in continuing and pursuing academic educational activities, both for ISMPO as well as for SARC Federation of Oncology?
Yeah, thank you, Purvish. I think we have made really good progress thanks to the virtual platform. I think it's really come in very, very handy, because our reach has been excellent now. And, it's very convenient. People don't have to waste time on travel, because traveling and meeting people was a big issue for during this time. So I think we've really done a very good job. We have been able to reach out to even remote areas across the SAARC countries and even India as well. So I think our reach has been very good, and very important information has been disseminated to all the people. And I think we are all much more educated today, and our connectivity, I think the frame of mind is that, okay, we can really connect to people at any time of need. And I think that is very, very important.
Fantastic. So true. Now let's talk about the second wave. And here I've tried to compare dates from when the first case came to the first 100 and the first 1,000 cases were identified, as well as something like that for the second wave. And you can clearly see that, in fact, India does not have a second wave as far as this documentation is concerned. Brazil did not have a second wave for a long time, but it also seems to be inching towards the second wave. So I will start with Dr. Shyam Agarwal. Do you think there is a second wave in India? And if yes, what is the likely projection that you think is going to happen?
Yeah, thanks, Purvish, for this question. So, as you've said, there's, I think a lot of people know my views.
Yes.
Because the virus, there are a lot of things which are unknown about the, how it really happens and what is really going on. So nobody knows why there was a delay between the Western countries and the SAARC countries. And to extend this thought, I mean, the Southeast Asian countries actually are missing in the second wave, not only the SAARC countries.
Right.
So why is that? For example, now the Delhi data which came in showed herd immunity coming in, because nearly 50 to 60% people in Delhi have been found to be having antibodies. So, that is extremely, important, because if that statement is correct and that information is correct, then how are we going to have a second wave unless we have a mutant population to which we are not immune to?
Right.
So, and the variant, for example, the South African variant or the Brazil or the UK variant, I think the government is doing a great job to my mind by controlling the spread of these variants, because you see there are hardly 300 cases or 4 cases or whatever of those kind of variants.
Right.
But the question is, why have Delhi or why have we people come to a stage of 50 to 60% antibodies? That's a very, very interesting and an important question to my mind, because of course the overall Indian data is only 20% or 25% of the Indians have the antibodies or they have been exposed to. So, I was just thinking, and this only came to my mind today or maybe yesterday. So we are a very, dirty kind of a country, especially, North Indians and all that. We spit all over, I mean, people chew tobacco and you're spitting all over the town. And people who are infected, and when they're spitting, so perhaps there is a distribution of the virus in the air, and with this kind of pollution, everybody kind of inhales that, and when you inhale that, well, then you are some of the viral antigens and the virus particles are going into your system, and maybe rather than having a direct contact with the person who has got the virus, maybe this environmental pollution in the air is responsible for such a high level of antibody in the Delhi population. Right. So if that be so, well, then I really don't see or foresee a huge wave coming in, especially in Delhi, where the seroconversion is so high.
Correct. And so also in Mumbai, some of the slums where the population was screened again showed a similar figure of between 50 and 70% of positivity, including patients who have never had a history of or symptoms suggestive of a COVID infection. Dr. Vijayanand Reddy, are you here? Have you joined? What is the situation in Telangana and Andhra Pradesh?
Dr. Vijayanand has not
Okay,
joined us yet.
okay. So I move forward. So this is the, as Deborah was saying, health workers and doctors were affected significantly. And this is the list of healthcare workers who died because of COVID infection. The red boxes are unofficial figures and the blue boxes are official figures. And if you look at India, 87,000 health staff have been infected with COVID and 573 are dead. That is the official figure. But if you look at the figure from Indian Medical Association, it says that among the doctors, the death rate is as high as 15%, whereas in the general population, the death rate was very low. So we asked, in a survey, we asked our colleagues whether they were infected or a relative living in the same house was infected, and this is the result that we got. So significant number of healthcare workers have been infected and they have probably transmitted to their other people in their homes as well. So there is a risk of increased risk to treating oncologists. And the question therefore is, should we do something differently for our protection while treating cancer patients who are COVID positive? So I will start with Dr. Hemant Malhotra and then take the opinion of Dr. Arvind Krishnamurthy. Hemant, go ahead.
So I think like what we were doing 6 months back at the peak of the pandemic, I think we should continue to do that. And I have told my team, and I follow that very rigorously myself also, that you presume that every single patient you are seeing, every single attendant of the patient you are coming in contact with has COVID and is transmitting COVID. And you deal with those patients and the attendants, whether outpatients or inpatients, in that way. So, and you know, next 1 or 2 months are also crucial. Most of us have had the vaccine, and we should not let our guard down for another month or two. And I think that's the only way of protecting yourself. Dr. Tariq and myself and Sham, some of us are 60 plus in age, and we of course need to be very careful. But our younger colleagues, our nursing staff, our residents, they also need to be careful. And we should not let our guard down. I think that is my advice to everybody.
Very true. Arvind, what is your opinion? Arvind, you will have to unmute yourself.
Yeah, anyway, thank you, sir, for having me in this esteemed panel. I entirely second what Dr. Hemant Malhotra, sir, has said. I think the more important thing is for all the healthcare workers is to get vaccinated. I think that's the most important strategy at this point of time. And I believe at least 30 to 60%, even in healthcare workers, there is some amount of vaccine hesitancy. So I think the message should be loud and clear, as has been that we should urge every healthcare and frontline workers to get vaccinated. I think that's the best form of protection at this point of time. I myself have got the vaccine and due for the second dose maybe tomorrow. Apart from that, apart from that, yes, exactly the same with regards to respiratory precautions. I think that's very, very important, especially when we are dealing with in the outpatient, when we are doing some procedures like examining the oral cavity and all, we really need to be very, very careful. So at least in our head and neck outpatients, we have stopped doing any scopies at the outpatient. We all sort of, reserve those scopies only after having these patients tested. But otherwise, apart from the respiratory precautions, previously we all were using the PPEs also. But now I guess that can be sort of, we can go slow on that, but respiratory precautions for sure. And apart from the other precautions of social distancing, masking, and seeing to it that you regulate the crowd in your outpatient. I think these are some of the things, and of course, testing of patients prior to doing any invasive procedures.
Perfect, perfect. So, how does a pandemic end? And I think the light at the end of the tunnel is vaccination. So, there have been a lot of questions because there is not sufficient robust level 1 evidence, and that is because clinical trials have also faced serious adverse events of not being able to complete whatever we have went out to do. So, Dr. Sahu, in the absence of great data, what is your opinion about vaccination? Arvind just mentioned vaccine hesitancy, and there has been a lot of chatter among the oncology WhatsApp and Signal groups about that. So, Sahu, I'll start with you and then ask Dr. Senthil Rajappa.
Sir, I feel this is a thing that where evidence will be still few months away. If you want to look at the data, how we normally practice oncology, it's still far away. But if I look at the risk and benefit analysis and the way it is going on, I would still feel that the benefit is more towards getting vaccinated than not doing so. So this is a peculiar scenario, and I feel I still would be erring more towards giving a vaccine, except for probably an exceptional situation where there's a neutropenia post a chemotherapy, deep neutropenia. That time I would avoid, but otherwise, in most of the cases, I would normally err towards giving vaccines.
All right. Senthil, what is your opinion?
I agree with Sahu, sir. So the simple answer is I've been vaccinated myself. So I think that answers your question best. Right. So we all understand the inadequacies in data, the problems with the clinical trials, and so on and so forth. In spite of all the inadequacies, I think that is the best weapon that we have to fight against this, difficult virus, should I say. But as has been pointed out by everybody, even if you've had the vaccine, I think it's important to make sure that you're following the social distancing, masking, and hand washing, and so on and so forth. So that all this together will get you to that near 100% protection that all of us want.
So very true. In oncology, we always look for a level 1 evidence in the ideal world. But so many times we face situations and patients where there is not even level 3 evidence. Absolutely. And then in the circumstances for that particular situation, whatever is best scientific and logical, we have to do. So I like your answer that in both you and Sahu have agreed and have been vaccinated like me. So we should go ahead. So Shyam mentioned about herd immunity and why Indians and other people from South Asia might already have partial immunity. So Nitin, can I start with you? Do you think that Indians have already a pre-existing partial immunity and therefore herd immunity is higher?
I don't. First of all, I'm very thankful to be part of the esteemed panel. To answer your question, sir, I think I don't have any scientific explanation to say that we already have a herd immunity. There are a lot of reports and a lot of literature saying that one of the panelists also pointed out that we are a relatively dirty country, to be quoting his words. So we tend to get more respiratory infections. So maybe we are exposed to the non-COVID coronaviruses, which may have cross immunological phenomena with the current coronavirus, that is the COVID virus, which may be responsible for lesser mortality or less severe outcomes as compared to the Western countries.
Correct. Amit, what is your opinion?
I was not very clear about your question here.
Do you think that Indians and people from South Asia have pre-existing immunity, at least partial immunity, and therefore our herd immunity is higher than what is in other parts
pre-existing
of the world?
As in before last year March?
Correct.
So there was this concept which Prashant and even you had raised in quite a few forums that we might have had some immunity to this virus. Even I have had a bad viral infection in 2019, and I was imagining that I might have had it. But we tested for our antibody level, and we were negative for antibody level.
Okay.
I don't believe in that concept that the COVID was released before and we've had some cross immunity. The Indians in pockets or in large segment have got a high incidence of antibodies, possibly reaching herd immunity, I think that's a truth, and that's a very nice truth, very kind of a joyful truth. So we're happy about it, but we're possibly getting infected, getting immunized, and so I think I agree with that, but not the pre-existent.
Got it. Dr. Sevanti, what is your opinion? Dr. Sevanti Limaya has joined us.
Good evening, sir.
Yeah, go ahead.
And so my thought for this is that unexpectedly the death rates in India were lesser than what we had expected. What example in Mumbai, and we saw in Dharavi, and the entire community could have been wiped out, and we didn't see that happening. So in essence, I feel that somehow we have had this basic immunity with which we have fought back. In addition, the herd immunity and the fact that there could be a lot of population-based infection happening, subclinical infection happening, sounds very genuine. Having said that, the hard data or hard evidence I don't have, and I whenever put forward such a question, I second giving the vaccination. And with that, I would just say, I was really interested in joining this meeting to hear what everybody had to say about the different angles of vaccination. And your questions for the survey were, they completely bowled me over. So thank you.
Thank you. So there is a hot race for the COVID vaccine, and the light at the end of the tunnel just got brighter. So this is the New York Times coronavirus vaccine tracker. And I've compared what was there on 6th January as opposed to what is there yesterday, that is February 18th. And you can see that the limited has become authorized, approved has increased from 3 to 4, and actually three additionals were abandoned. So as Dr. Ghaffur mentioned, India has crossed 10 million people having been vaccinated, but we are still behind the United Kingdom, European Union, China, and United States. So that is where the vaccine hesitancy has come. And Arvind mentioned about that. So earlier we had done a survey and asked doctors, if COVID vaccine was available to you today, would you take it? And this was several months ago, before the vaccine became available. And 72% had said yes, and 21% had said no. So Deborah, are you facing vaccine hesitancy in United Kingdom? What is it that is the perception among the healthcare workers in the UK?
I think overall the uptake has been very good, although there have been some reports of perhaps a slightly lower kind of uptake than expected. I guess I can see what I can report on what I see around me, but I don't know of any colleague who has not been vaccinated. And I think, as someone said before, I think giving the right example, showing the right kind of example to patients, I, for instance, took part in the AstraZeneca trial back in July.
Wow.
Obviously, it was blinded. But I told my patients about this, and that often created a very positive response in terms of, how involved we were. And again, only a few patients, I would say, are hesitant. The vast majority of our patients, because we started vaccinating on the 8th of December, have had their vaccination already. But I think overall, the uptake, and especially in the kind of the kind of front-facing, patient-facing clinical specialties has been good.
Awesome. Dr. Mohapatra, what has been your opinion or experience about vaccine hesitancy among your colleagues?
Sir, in the beginning, there was some hesitancy, actually not much in the doctors, actually, nurses and other workers. But once the vaccination started, they saw vaccine, there is safe and nothing, no side effect. Now everybody is taking the vaccine, sir. There is no issue taking vaccines.
So just yesterday's results are that in the city of Mumbai, there were 136% people vaccinated. So they had decided a particular amount to be vaccinated yesterday, and more patients, more people showed up, healthcare workers, and they were able to do more. So
yes,
that's
sir.
a good sign.
Once it started, people they saw this nothing, no complications. So everybody is coming up.
Excellent. Now, curiously, in tier 2 cities, there was an increase in the number of patients, cancer patients receiving chemotherapy. So while traveling became difficult and they were not able to go to big centers, they were not just sitting at home and not taking treatment, but they were seeking the treatment at nearby centers. So the question is, are cancer patients more vulnerable to the COVID infection? We did this survey and this is ongoing. So far, we have received 99 responses. So we can say that it is the percentage and the absolute numbers are the same. And 87% of the people said that cancer patients are more vulnerable to COVID infection. So also 84% said that if the COVID infection does take place in a cancer patient, there is a higher risk of either severe infection or death. And this has actually been collaborated by data from Pune, which is in press and therefore I am not able to share with you. So I will like each of the panelists to say a quick yes, no, whether they feel that cancer patients are at high risk, and if they get the virus, will they have a high risk of severe infection or death? Deborah, can I start with you?
Thank you. I think from our own data, we haven't seen that in terms of more infectious or more harmful to specifically to cancer patients. I think the data shows us that it's to do with age, other comorbidities, especially obesity, diabetes, hypertension. I don't think specifically having a solid cancer and being on chemotherapy exposes you at higher risk. No.
Right. JP Agarwal, what is your opinion at Tata Hospital?
Good evening, everybody. Definitely, I think they are on a higher risk, and definitely the more of a hematolymphoid ones are much more higher risk than the solid ones.
Right.
And even in solid ones who are receiving full-fledged chemo, they are a little bit on a higher risk than receiving radiation. But I wanted to say, I wanted to say something before.
Please go
Can
ahead.
I?
Yeah.
So regarding the second wave, so definitely we will not have a full-fledged second wave, but definitely it is going to simmer up for a long time. I completely agree on the distorted immunological behavior we have, but we have not proven them on the basis of this virus. That is second. Third is we discussed about the mortality among the healthcare workers. But the morbidity of the psychological disturbances is very, very alarming. So we did a big survey, and especially it is there more in nurses and the radiation oncology therapists and those. And it is just going to be published. I think it is in the part of the global oncology. So I am shut on that. Lastly, what I am saying, we as a healthcare leaders, we have to vaccinate ourselves without doubt, no hesitancy, so that we can definitely say others can get vaccinated. That's what I wanted to say.
Perfect. Govind, what is your opinion about vulnerability of cancer patients to the coronavirus?
Yeah, since I'm taking care of adult oncology patients, and most of our patients have comorbidities, if not diabetes, which is quite prevalent, hypertension as well. So I think these comorbidities add to the problems that we have. And just to add to JP's, the mental issues of the people and the health professionals, our government actually has a helpline that is there, and anybody can call there and get counseling. So I think that is very, very important.
Perfect. Hemant, your opinion, please.
Yeah, so my feeling is that the very initial reports which came out of Wuhan on a small number of patients, two-digit patients, suggesting that the mortality in cancer patients who have the COVID infection is higher, that probably was overestimated. And the large report from New York, that kind of put the question to rest, and the publications from England also put the question to rest. The mortality is more related to age and the comorbidities which the patient has, rather than just having cancer. Now, your second question regarding vaccination, I think I would suggest that all cancer patients get vaccination on priority, and maybe we can request the government to move this category into the priority category, all cancer patients. Only two possible categories. One is patients who are due or receiving hematopoietic stem cell transplantation, and the second, patients who are receiving rituximab for whatever reason. Those are the only two categories I think who should not be administered the vaccine. That's my opinion.
Right. Nitin Bansal, what do you think?
I work in Rajiv Gandhi Cancer Institute. So we
Yes.
had around 600 odd patients of cancer infected with COVID admitted with us, and the mortality rate was close to 7%. So if you compare with general population, I think any other tertiary care center which admits mixed population, I think the mortality rate was almost similar. But we had the important point was that we our patients tend to stay in the hospital for a long time. They recovered very, very, very slowly as compared to other non-cancer patients.
Right. Sao, what was the experience in Bhopal?
Sir, we had admitted, well, I had admitted under me some 5 patients, and all of them recovered luckily. The experience in Bhopal from AIMS, I had the colleague who took care of the COVID in AIMS, and he felt that the cancer patients, including the immunosuppressive patients like this called kidney patients, the renal failure and CKDs, they somehow the mortality was low. The recovery was longer, as Dr. Nitin rightly pointed out, but it was slow, but the death was lower than the normal non-oncology patients. I also felt the
Very
same
interesting.
here.
Yeah, yeah. Arvind, what has been your experience at Adyar Cancer Center?
We are still pooling our data on this. But at least from what evidence I've gleaned, I actually found that the case fatality rate was pretty high in cancer patients as compared to non-cancer patients with COVID-19. So I think in some studies, it's more than double also.
Right.
So I'm really concerned. The reason why we are actually asking the cancer patients to be put on priority is basically of the logic that these patients are more vulnerable. I tend to believe that although this may not be reflected in the Indian data because our mortality and morbidities have been slightly lower, but in general, from whatever is the published data I am able to gather, I find the case fatality rates seems to be pretty high. So this is my take. So that's the reason why I would sort of urge, and I second Dr. Malhotra's claim that we should urge the government to consider all our cancer patients as priority for the same reason.
Absolutely. Amish, in your boutique clinic, what has been your experience?
Thank you, sir. I thought you had forgotten me to
Not
ask
at all.
questions. Sir, I had a slightly different opinion from Dr. Arvind and Dr. Hemant, probably because of my boutique daycare scenario. We had
like always, Amish.
We had 17 positive COVID cases, out of which 15 were solid tumors and 2 were leukemia. All 15 solid tumors, not only they all recovered, none of them required any admission. One. And second thing is 2 leukemia, 1 myeloma. Myeloma patient required 14 days of ICU care and recovered. 1 leukemia patient was on acute promyelocytic leukemia on induction treatment, developed COVID and died. Another leukemia patient who was on maintenance ALL and had 14 different tests of RT-PCR, all were positive.
Wow.
So we don't know whether it was a dead virus which was being picked up or whether he was shedding virus for a long time. Finally, we stopped doing and continued his treatment because we could not delay the treatment. So that has been my experience. And also from New York, as it was mentioned, the solid tumors I don't think reduces T cell or B cell immunity because chemotherapy do not do any major harm. And they should be treated equally. We have enough evidence now that they should be treated equally as somebody who's not having cancer. This is my perception. Vaccines are except for the 2 groups which everybody mentions, right from Dana-Farber to ESMO, bone marrow transplant patients and patients on CAR T cell and others, where you have to wait for a certain time. I think every solid tumor cancer patient should receive vaccine. In fact, 2 of our patients who are doctors also, they got a call and they went and vaccinated themselves. Nothing has happened to them right now. We are waiting for the second dose.
Perfect. Yeah, as a part of Gangaram Hospital, you have been dealing with COVID as a frontline warrior with so many patients. And you have also innovated on how to protect the healthcare workers. So what do you think is the situation?
So, we've had a large number of COVID positive, even, we are focusing on cancer patients.
Yes.
I think in just short, the infectivity was high. There were a large number of patients, but I really didn't find a very high mortality because I think most of the patients did recover. So that would be my experience.
Right. And Amit, you are also at a very large center. What was your experience? Amit Agarwal?
I wrote down the chat box. We documented 135 patients. And I think the patient which could be attributed to death were actually 6, in which we could say that it's a combination of COVID and chemo. Had the COVID not been there, we would have not expected that. So our mortality rate is hovering in solid tumor about 5%. Very few hematological patients because we have a separate hematology unit. I'm just saying what everybody is saying. Not extremely high, but I think it's slightly higher than national average of around 2.5 or 3%, but not like what we initially felt that we will have a disaster in our hand.
Got it. Dr. Vijayanand Reddy, has he joined?
No,
So
sir.
can I?
Yeah.
So you presented a slide where the medical workers or the doctors had that way the highest mortality. So if you look at the general population, cancer patients and doctors serving patients, I think doctors had the highest mortality. That is something which is very intriguing, sir. I just wanted to point that out. That's all.
Sure. I agree with you. Sevanti, in KDA, what has been your experience?
So, sir, mainly, again, second everyone's experience, I had patients who had COVID, but I treat only solid tumors. So each one of my patients recovered. I don't recall a single mortality in my patients that I treated. I had an aunt with who I was getting treated with my hematology colleague here. She had lymphoma and she was in remission. But after last dosage, she got COVID and she passed away. I also have a melanoma patient on clinical trial who made it through COVID infection and made it back to the study. But her 40-year-old son with diabetes passed away. So in my experience, the solid tumor patients managed okay.
Right.
At our center. I've been very alarmed because of the Western data, and we've managed very carefully, but didn't have the same unfortunate experience, and thankfully patients have been safe.
That's good news. Dr. Mohapatra, what is the situation with you?
I lost a lot of patients, sir. Especially lymphoma patients and lung cancer patient at the beginning actually. And our center actually, the whole center sometimes got infected. Actually, whole ward, one patient, and they infected the whole ward.
Wow.
To stop the ward for a week also. It's a situation where like that.
Right.
And actually, I lost a lot of patients actually.
Okay.
Especially old age and lung cancer and hematological malignancies.
Got it. Senthil, last word on this from you.
So I agree with everybody, and that's the last word that I have to say. So it's very similar, sir. So I think there's a slightly higher risk of infection. But solid tumor patients, even those who are taking chemotherapy, I didn't see that the mortality was higher. It was less than 5%. We had 20 odd patients whom we admitted at various points in time.
Right.
Yes, patients with hematological malignancies had a higher likelihood of succumbing to COVID, but I think the solid tumor patients did quite well. I can only remember 1 or 2 patients who were on chemoradiotherapy already with bad mucositis and so on and so forth who succumbed. But otherwise, our experience has been quite good, should I say, and hopefully we have seen the end of it.
Perfect.
Sir, can I raise a point?
Yeah, please go ahead.
So we had a small experience with lymphoma. We don't treat lymphoma. Very few lymphoma patients, and most of them did not make anti-nucleocapsid antibodies. So this is something which I would want everybody to take the message that at least the nucleocapsid antibody is not formed in patients who are on rituximab. And I think 2 of our patients retained RT-PCR positivity for 60 days while they have had rituximab. So I think this is far above what has been documented. I think most of the data set talks about 42 days. You can have persistence of antigen/virus, but 2 of our patients had at least for 60 days. So I think that is an important thing to know how we proceed.
Thanks for sharing, because I think this is valuable information for all of us. This question has already been answered, so let's go on. If the cancer patient is to receive COVID vaccine, which of the currently available vaccines in India would you prefer for your cancer patient? And this is comparing the 6 contenders. So, Sahu, if you had a choice, which vaccine would you take among all the approved ones?
Sir, I think we have only option of 2. So I would go for Covishield just because I have at least the data with me for phase 3. That's the only reason.
So there has been some perception that Covishield is less effective against some of the variants which are more virulent.
The South African variant and the Brazilian. So I understand that, but we do not have the variant. But sir, I would like to see the Covaxin data. Okay. No one knows how.
Right. Amish, what about you?
In addition to what Dr. Sahu has said, I think Covaxin theoretically sounds better than Covishield in terms of cancer patients. Sir.
Right.
Short of data, we have to follow what the guidelines say. I have a feeling that Covaxin would prove to be more safe and efficacious, especially in cancer patients.
Right. Right.
Just to say one single point to Dr. Amish, they are not including the patients, and that is, if you look at the contraindication to Covaxin, actually they are more stringent towards immunosuppressive patients. At least Covishield
they do not have any amnesty against any deaths or any serious adverse events, and that's the reason Covaxin has come out with all the factors where they refuse that these type of patients should not take. But if you see the theoretical aspect of Covaxin versus Covishield, I think Covaxin will score over Covishield. That is, we will discuss this after 6 months. I think so.
We agree to disagree, and let's move on to the next one.
Can I make a comment, sir? Parvesh?
Go ahead.
Sir, so far, Covaxin, as you know, is in the clinical trial mode. That's why Bharat Biotech leaflet say we should not give it to people with low immunity. So if you follow the instruction from Bharat Biotech, until we get a full license for the drug, we will not be able to give Covaxin to immunocompromised patients. I don't think government has this particular stand. For many centers, they are giving Covaxin to healthcare workers who are immunocompromised. So we may have to clarify that with the health ministry. What should we do for the time being with Covaxin? Because some centers will only give Covaxin. And as per the BBI, you can't give it to immunocompromised patients. So we should ask health ministry very clearly for instruction regarding Covaxin for our cancer patients until we get the full data and licensing of Covaxin.
Right.
I think I agree with Dr. Ghafoor. The reason why there is like a lot of exclusion criteria for Covaxin is because it is still being used in a clinical trial mode, so to say. And there are some compensation issues attached, so they are being very, very careful. Once the full data is submitted to the DCGI and it is approved for marketing, then maybe most of the exclusion criteria which are relevant to clinical trials, they will not be there like for the Covishield.
Perfect. Now, this is a very important question because among the responders for today, almost half were not sure. So the question is the COVID-19 vaccine less effective in cancer patients as compared to the general population? Can I start with Deborah, please?
Thank you. I don't obviously have a definitive answer for this, but I hope, and I'm actually quite confident that our team here at Guy's and King's College London will actually publish on this within the next maybe 2-3 weeks. Because we started vaccinating early on the 8th of December and we had categories, so it was over 80 plus, and then slowly it went down, and then from mid-February or early February, we've been vaccinating all cancer patients in that category. So she has, Sheba Ershad, one of my breast oncology colleagues, has data on 150 patients with solid and hematological malignancies with immunological monitoring before and after vaccination. And without giving away too much, it shows that I think the solid cancer patients tend to respond as we would with healthy volunteers, but some of the hematological patients have very poor responses following either 1 or 2 vaccinations. So I think it's still out, it's to come, but we've got some really helpful data to kind of help us. I think the bigger picture, and perhaps we'll come on to that later, but we've also collected safety data on side effects now on many hundreds of patients. And apart from many kind of sore arms, some headaches and some lethargy, we haven't seen any real concerns in either group. So I think, is it safe? I think we can say, yes, it is. Is it effective? Perhaps for some cohorts, it might not be.
Right. I think this is very important information. Thank you for sharing that. Now, do cancer patients receiving the vaccine require special monitoring? And again, here there was a difference of opinion. And the other is, what is the best time to get the COVID vaccine for cancer patients? Is it immediately? Is it after 1 month, after 3 months, after 6 months? So let me ask Deborah first. Should all cancer patients, except the 2 exceptions already mentioned, receive the vaccine as soon as their turn is due?
Yeah, I think so. I mean, I'm also, what I forgot to say in the beginning, I'm also the lead for systemic therapies at the Trust. And in early or mid-December, we obviously got a lot of questions from colleagues around us within London, but within the UK about, the safety and when should we vaccinate. And we drew up some guidelines for this, which have been adopted by the UK Chemotherapy Board, and so are used within the UK. And it very much reflects on what was presented earlier. It's about, being very pragmatic with giving out vaccinations and not creating multiple trips to hospital.
Right.
And we are trying to vaccinate and are quite efficient in this, at least locally in our centre, with anyone who's been diagnosed with a cancer, whether they're going to have surgery, radiation, chemotherapy, or combination therapy. We get their first vaccination in as soon as possible. We can generally vaccinate them within the next 2 days. And then depending on what regimen they'll have the next dose when their counts have recovered. So I think there needs to be a very pragmatic approach to this. And,
right.
and we favour vaccinating everyone unless there is a real good reason not to.
Right. JP Agarwal, do you agree with that?
Yes, sir. Incidentally, last week I saw one physician with a vocal cord tumor. I said, go ahead, just take it.
Right.
So in solid tumors, I think whichever patients I head, neck, etc., unless until we are depleting their lymphocytes, etc., there is no evidence not to give, sir.
Correct. Arvind, you agree with that, right?
Yeah, I agree. The NCCN guidelines say so.
Yeah.
Dr. Gafoor, in fact, had a very elegant presentation. Almost,
correct.
I felt that I had nothing more to add after listening to this presentation.
And Sevanti, you also agree with that? We can't hear Sevanti. Okay, I'll move on. So what about delaying the second COVID vaccine? So there has been a lot of talk about the UK in trying
Yes, sir, I agree. And no timing bar, no every patient can receive it anytime.
Excellent. Thank you, Sevanti. So there is this discussion about delaying the second COVID-19 vaccine dose, and there have been pros and cons. So Hemant, what do you think? India is also contemplating postponing the second dose. Hemant, what is your opinion?
So, Purvish, I think the only reason why you should consider delaying is if there is shortage of the vaccine.
Right.
If there is no shortage of the vaccine, then we should follow the protocol which has been tried and tested and proven in clinical trials.
Perfect.
I would feel that unless we have data to prove that delay is as good or better, we should stick with what has been recommended in the clinical trials.
Right. Shyam, what is your opinion?
And then some thought. So,
Shyam, we can't hear you. While Shyam is getting it sorted out, Senthil, can I ask you to give your opinion? Senthil?
I'll come in, Sahu here.
Sahu, please go ahead.
Yeah. So what I feel first is that definitely do not take it early. That is the basic message. But the data is definitely pointing towards, even the smaller data that is coming out, trickling in, is that probably little delay is good. And I feel, but yes, I agree with Dr. Hemant, that is the trial is 28 days. I'll stick to that till the data comes out. But I always, my inking is that probably 2 to 3 months, the second dose will have a little better immunogenicity. But
perfect.
That's
right.
So can I just clarify one point?
Please go ahead, Gafur.
Our National Technical Advisory Committee of Immunization, NATAGI, has met today.
Okay.
So I haven't yet got the feedback what their decision was. And based on that feedback, Health Ministry will decide. So within the next few days, we'll get an official decision from Health Ministry on this, whether we can delay the Covishield second dose or not.
Okay. I think that we'll wait for that. Yeah, Shyam, go ahead.
What do you feel, Dr. Ghaffar? What is your take?
See, the trial evidence from the Oxford vaccine, the antibody titer and the efficacy is better if you delay for 3 months, 12 weeks.
Exactly what I'm
In fact, 6 weeks, the efficacy is 54%, and 12 weeks, it is 85%. Huge difference. But so far, our Union Health Ministry decided to go ahead with the existing 4 weeks protocol because of logistical issues. But a lot of discussion has happened, and today NATAGI has met. So within the next few days, we will get the final decision for the government.
Right. Shyam, you were saying something. Please go ahead.
I can only share some facts with you. I was vaccinated on the first day along with 95 other healthcare workers. And after 4 weeks, I actually went a little late at say 4:30 p.m. towards the end of the day, and only 57 had turned up for the second vaccine on the 28th day.
Right.
And I'm getting a lot of calls from friends that we don't want to take the vaccine on 28th day. We want to postpone it till the 6 or 8 weeks because of the data which is available.
Wow.
So, this is what is happening in real life.
Yes, true. So cancer patients who have recovered from COVID-19 infection, should they get vaccinated? Majority said yes. So these are some of the reasons why there could be a scientific basis to say that patients, even if they are infected, should get the vaccine. So Govind, I will start with you. What is your opinion?
Yeah, I totally agree on that. In fact, there is a thinking that many people in India have been infected. So the first dose itself could act as a booster dose. And people are trying to see if we can actually measure the level of antibodies and could we avoid the second dose in them. So I think, this is a very nice thought process, but we need to back it up with evidence.
Amish, what do you say?
So in addition to what Dr. Govind Babu has said, in fact, Dr. Debra in chat box right now has said many of her colleagues who were COVID positive in early 2020 and antibody positive, all of their antibodies have been washed off. So I think going by that fact, also patients who have recovered from COVID infection should also get vaccinated. Whether 1 or 2 needs to be seen.
Right. Dr. Mohapatra, what is your opinion?
I agree with Dr. Govind Babu, sir. If somebody has an antibody, 1 dose may be, because we have a huge population and constant of vaccine, 1 dose will be okay.
Right.
Purvish, can I make a comment?
Yeah, Hemant, please go ahead.
I think deciding further course of action by antibody levels is pretty dicey because standardization of antibody testing and interpretation, even patients who have had frank florid COVID, they show no antibodies. So that has to be, done with a little bit of caution, and making treatment decisions or vaccination decisions on antibody levels, is kind of, I kind of would hesitate to do that.
Sir, I would like to second Dr. Hemant, and I just watched the ITSA and the ASCO webinar 1 hour on vaccination. So they were very clear about it. What antibody to test, no one knows. What titer are you going to look at as a safe value, no one knows. Do you have that in your lab to test it? What is the authenticity and validation, no one knows. I think we are just treading on a path we do not know. I think we should be just going on vaccinating without antibody.
Hemant, like I said, this is just hypothesis generating. We don't have any great clinical data for this.
Yeah, and I think the untreaded path, so many unknowns is the bottom line of dealing with this COVID infection. It's
definitely. But just hypothesis generating and thought for future.
So talking about rituximab, I think we have already covered that. So also for stem cell transplantation, so I will skip this part. Can patients with active malignancies be simultaneously administered other vaccines along with COVID-19 vaccine?
So just one second, sir.
Go ahead.
So stem cell transplants, there are some transplanters here. What I got from that thing is that they are telling us that in 3 months they could vaccinate the stem cell transplant patients post 3 months.
Right.
What is the take of this panel who does stem cell transplant? Anyone?
Right. Please go ahead.
Dr. Hemant, would you just tell that no to stem cells, or I felt the ASCO told that after 3 months you could do it?
You know, I would probably follow the guidelines which are there for vaccination, other viral diseases in the stem cell transplant setting, because that population is so small that it's going to be very difficult to generate data. So I'll probably, extrapolate the recommendations for other viral infections in the stem cell transplant setting to COVID till we have more data. And, this is uncharted territory, and it's very difficult to make an evidence-based decision over here.
Hemant, I think it's a very prudent statement that you made. So I hope that satisfies you. So what about other vaccines? And this was touched briefly by Dr. Ghaffur, but I would still like to ask you. And also a question about travel restrictions for cancer patients after they have received the COVID vaccine. And if the patient has already been vaccinated and now develops COVID, should he be treated in the same manner as a non-cancer patient? So again, I will ask the opinion of each and every one of you. Deborah, we can start with you.
Sorry, I was just answering a question about the duration in between vaccines, what we do in the UK.
Right.
And actually, at the moment, we are, so this is government advice. We are vaccinating the general population every 12 weeks or 12 weeks in between. But as oncologists, we have flexibility with regards to patients on cancer treatment. And as a group, we've said that patients, sorry for the noise here, apologies.
No problem, please go ahead.
It will stop in a minute. That we can, for those patients who are due to start chemotherapy for hematological malignancies, we can reduce that to kind of 3 or 4 weeks because we give the Pfizer or the AstraZeneca vaccine here. But we can actually make individual decisions for our solid cancer patients too. But for the general population, it is 12 weeks interval.
Okay. So I'm actually running out of time. So any burning concluding statements that any one of you would like to make? The mic is open for all of you.
So
can I,
Amish?
Yes, Amish, go ahead.
Sir, Dr. Debra, this question, and maybe any of the panelists can take. The 12-week duration, is it because of the trial efficacy which was shown, or is it because you can vaccinate mass population? As Dr. Hemant said, if the vaccination is available to each and every person in UK, would the interval still be 12 weeks? That is the question.
Yeah, no, I think it's certainly a pragmatic. It's not based on trial evidence. So there was obviously pushback from from groups, from clinicians, especially those working in the field of cancer, that are used to deal with trial evidence. But no, this was to allow to have a first dose into as many patients or the population as possible. And obviously we've vaccinated now more than 16 million people. But it might change now. We know kind of how many people have been vaccinated, but at the moment it remains 12 weeks. I think perhaps one other comment I would like to make, and that was relating to the excipients with the PEG and the polysorbate. We looked at our patients who'd had taxanes with docetaxel or paclitaxel, who'd had a hypersensitivity reaction in the last 6 months. And we looked at about 60 patients who then subsequently had the vaccine. And obviously none of these patients had true I think none of them had true anaphylaxis, but they had significant hypersensitive reactions. And we saw very few issues with the vaccine that we gave. Most of these patients had the Pfizer vaccine. So that was also reassuring. I've shared the guidelines with you, and that actually has a table with regards to kind of allergies and what to give, and perhaps how you might want to discuss with an allergist beforehand.
Perfect. I'm sure that we have a lot of questions from the audience, so we'll take those questions now. This is from Meher Dubash. I'm on oral chemotherapy for advanced breast cancer. I'm on a monthly injection Xgeva and tamoxifen, cyclophosphamide, also methotrexate. Under these medications, am I eligible for the COVID vaccine? I have not taken the flu vaccine earlier. Deborah, what would you advise to such a patient?
My advice would be to have the COVID vaccine. I don't know when normally the flu vaccine is given in India, but I wouldn't do that first. I would have the COVID vaccine, wait for a few weeks, and then have the flu vaccine at some later stage.
Perfect. From Dr. Rajesh Jindal, is any one vaccine better than the other? Will a booster dose be required some months later? I think the booster dose question has already been answered, but is one vaccine better than the other? Govind, what do you think about it?
I don't think we have any data to say which is better than one another. No.
Okay. From Dr. Mohapatra, how do we know these antibodies are protective? So Hemant clearly mentioned the answer to that. We don't, and Gafur also put in the word, we don't really know. Sham has said when to vaccinate a patient of lymphoma who is on maintenance rituximab being given every 3 months. Deborah and Gafur, if you can put in a word on your advice for this.
Very, very tricky question. Now, the patient is on rituximab every 3 months. So the antibody response is going to be very minimal. But at the same time, we can't postpone the COVID vaccination forever. We are in the middle of a pandemic. So we may have to go ahead and give the vaccine. Probably what we can do is once in every 3 months. So probably 6 weeks, we have a 3-month gap in between. So, so 6 weeks in the midway could be the best time.
All right. And then the second dose would also be again after 3 months. So that is again midway.
That's the problem. You know, we can't now, if we get a permission for the Covishield at 3 months, we can give it after 3 months.
All right.
So that will fall 6 weeks after the next dose of rituximab.
All right. Excellent. So from Dr. Amish Vora, are we delaying second dose as per Covishield data submitted? So this is, we are waiting for the government's decision. From Dr. Kalai Chelvi from Chennai, vaccination for patients above 80 years of age. I think that should be a priority. What do you think, Deborah? What are you doing in the UK? I believe that they were number 1 on the list, right?
Yes, I think we certainly vaccinated. That was one of our first groups that we vaccinated, and I don't think a reason why they shouldn't receive vaccination.
So my father is 90-year-old, and I'm just waiting for the first opportunity to have him vaccinated. Fortunately, he doesn't have any comorbidity. How your question is all?
I'm here, Purvish. I'm waiting for vaccination for my dad to 92 years.
Right. Sahu's question has already been answered. Can we go to the next one? From Dr. Sonali Chatterjee. Vaccines in those receiving immunotherapy. Gafur, can you repeat what you said in your talk?
Yeah. See, if a patient is on anti-CD20, the vaccine antibody response is going to be poor. And cell-mediated response, the T-cell response, may have an acceptable T-cell response. So we have to give the vaccine anyway. We are in the middle of a pandemic. So just go ahead and give the vaccine when offered, but try to get a maximum gap from the dose of rituximab.
Perfect. From Vibhuti Saha about Covaxin literature. I think the literature is more to for the pharmaceutical company to protect itself against litigation rather than actually on the risk of the vaccine. So our opinion has already been discussed, and I don't think there is a real need to discuss that further. From Nazneen Nahar Begum, can an HIV positive patient with cancer receive the vaccine? Deborah first and then Gafur. Can you go back to the previous slide, please? Yeah. HIV positive patient with cancer, should he receive the COVID vaccine? Deborah is nodding her head, so she's saying yes. But she's muted, so we can't hear her.
Sorry, I think the internet is a bit unstable here.
Okay.
Yes, they should. They can.
Right. Abdul, what is your opinion?
Oh, yes, I agree. Of course, we have to vaccinate.
Excellent. Next question. Seventy has asked, how long should we recommend patients to wear masks after completing vaccination? Do we check for antibodies? So the second part is we don't know the answer to that. But wearing the mask should be definitely for at least 1 month after the second dose. Is that right?
Forever. I would say forever.
Forever.
Because even if the vaccine, even for an immunocompetent individual, the vaccine efficacy is not going to be 100%. So we have to wear the mask forever.
Right.
Yeah, I agree with Dr. Ghaffur, and that should be a clear message from this panel.
Right. That normal precautions, wearing masks, washing hands, keeping distancing is something that is a new normal, and we should live with that. Elderly survivor CA rectum, is it okay to go ahead with the vaccine? Absolutely okay. Please go next. Is that the last? Oh, wonderful. Last question is over. I think though we ran out of time, we've done a good job. I hand over back to Dr. Raja for the concluding remarks. And I thank all the esteemed panelists for being here available to us and making such valuable input. Dr. Raja, over to you.
Thank you, sir. Thanks for very, very entertaining and engaging conversations and various very, very learned people. But it was very intriguing to see how there can be always questions, and there can be also always very frank sharing of views. That's very wonderful to hear. And all of you, I thank all of you for frankly sharing your views, and some of you agreed and some of you agreed to disagree. So that's the way to go. And I especially thank our overseas colleague, Dr. Deborah Enting, for active participation, and also for sharing the valuable document from the UK Chemotherapy Board. I share the Prime Speaker, Dr. Abdul Ghaffur, for a wonderful lecture, and Dr. Parvesh Bhai to lead the entire elite oncology panel in the country. For all the panelists, very senior oncologists from the length and breadth of the country, and for all the colleagues, delegates who have joined us, and for all my friends and colleagues in my unit and my hospital who have helped to put up this show. And thank you, all of you. I think very, very pertinent messages. Masks forever, and hand washing forever. I think it is wonderful, and vaccine hopefully is the light at the end of the tunnel. Thank you so much, all of you, for joining us.
Thank you, sir. Thank you.